Welcome back to the Big Ideas Theater here at AARC. I'm Ed Highland. I'm joined now by Doug Gardenhire, who's with Georgia State University. Doug, thanks so much for coming by.
Thanks so much for having me.
I want to talk a little bit about pharmacological management for asthma. The first thing I want to ask is seems like there's an awful lot of over-the-counter medications that are available to patients. How is that impacting the job of the RT in helping these folks?
Yeah, there has been this resurgence really of aerosolized epinephrine and racemic epinephrine that's over the counter. And I think that puts in a really big issue for us as respiratory therapists as we treat them in the emergency department. There's a lot of much better pharmacological agents to treat asthma. We have a lot of different strategies that can really assist the patients in managing that. And unfortunately, over the counter epinephrine and racemic epinephrine is not the way to treat that. Those are going to create a lot of issues for those patients long term, and in that time, for us as respiratory therapists, seeing them in the emergency department could make it a lot harder to treat them for their asthma.
Now, do you think the patient's use of over-the-counter products is lack of education, or would it be more economic?
I think it's a little bit of both. I think that it is very easy to get because it's over the counter. The cost is some issue, but the good news is things such as albuterol and levalbuterol, they are now available by prescription, but in a generic form. So that's some help in terms of the relief and the cost.
Sure, brings that cost down.
Absolutely.
Let's talk a little bit about some of the changes in the treatment for adolescents versus adults.
Well, really the big thing that we see in the new GINA 2019 guidelines for both those who are 6 to 11 and then those children 12 and to adult is what the literature tells us is providing medication that's not necessarily FDA approved here in the US. So what we talk about is that using that off-label. And the drug that we see the most use and now we see as the primary medication is going to be budesonide, an inhaled corticosteroid, along with a long-acting beta agonist such as formoterol. And that's where we're going. Outside of the US, we have this combination of a short-acting beta agonist along with an inhaled corticosteroid, but that has not been approved here in the US. So this change that has occurred for all of those patients has kind of moved from just having a PRN short-acting beta agonist to really treating on a PRN basis, which is what we're not used to, with an inhaled corticosteroid and a long-acting beta agonist.
I'm going a bit off topic, but it's always amazed me how respiratory therapists, clinicians have to take care of whatever is happening right now with current available technologies and methodologies, pharmacologicals, but also what's on the horizon. What's coming up, and so you have to have that at least in the back of your mind.
Sure.
As to, gee, if I had this, or maybe one day when I have this, it will allow me to help this patient even to a greater extent.
Right. There's so many different agents that are on the market, so many different things to select. When we think about all of the technology, all of the research that's going on out there, what we do know is what we have that is available, even though they're a similar product, such as an inhaled corticosteroid, they may work differently on different patients. So, brand A may work on patient A, but not on patient B, and vice versa. So we have to be able to talk with our patients, educate our patients, and find out from them what it is that they need so that we can find the right medication, the right treatment regime for them.
And in that vein, where do we stand on monoclonal antibodies?
Well, monoclonal antibodies are huge. Really, all of these biologics, we're seeing more and more of them, and we're seeing new, in terms of asthma, approval because of their use. So we've got several new products on the market. There's going to be one that's going to be hitting the market here really soon, just finished up phase 3 trials, so I think we're going to get a new drug application very soon for them, and it'll be on the market. But they're really, really good. They're really safe, a lot safer than what we really think that they are. They're very safe. Those things that happen in terms of the side effects are very, very, very rare. But we're seeing a lot of positive outcomes, and those are things that patients, and I think respiratory therapists should talk to their patients so that we can get with all of our other healthcare practitioners to see if that's the right treatment for them.
And these are more targeted, these therapies?
Yeah, these therapies are targeted for certain individuals, and really it's for those individuals that we cannot control their asthma with the other pharmaceuticals that we have, such as short-acting, long-acting beta agonists, inhaled corticosteroids. When we have problems with those, we've seen that moving to this monoclonal antibody seems to be very functional for them, and we're seeing a lot of good results from them.
Well, hopefully the arsenal will continue to increase over time here.
We hope.
Doug, thank you so much for coming by and joining us.
Thank you so much.
This is the Big Ideas Theater at AARC. I'm Ed Highland.